things that can prolapse down there: the uterus, the bladder, or the rectum. Then I want to talk about physical fitness and whether or not this can help prevent dementia. Then the following topics are really for men and women. I want to go over the recommended vaccinations for people once they hit the age of 65. I want to talk about a very important topic, which is hearing loss. Then coffee and tea. And you might say, well, what does that have to do with aging? But I'm going to show you. And then I want to go over some myths about getting older. In our practice, we treat patients who start at age 65. Our oldest patient right now is 107. So you can imagine that there are quite a bit of variations between 65 and 107, and they often have nothing to do with age. All right, so let's get started. First of all, do you know in your mind what the number one cause of death in women is? We have all kinds of things that we hear about every day and that we're nervous about. We have cancer, we have corona, we have heart disease, we have dementia. So the question is, do you know what the number one cause of death among women is in the United States? And then I want to show you a very interesting study where they ask doctors, do they know what the number one cause of death in women is? So it is heart disease by a great margin. And actually, even though I've been talking about this and seeing it in patients for years, it actually came very close to home last month when a very good friend of mine who is in her mid-60s, extremely fit, goes on these bike rides with her husband, who is a physician, and bikes 25 miles a day, has no family history of heart disease, was on no medications, and woke up in the middle of the night with terrible nausea, vomiting, severe sweating, drenching sweats, chest pain, abdominal pain. And they both assumed that she had eaten something. But when it seemed to be getting worse and worse, he finally took her to the emergency room where they did an EKG and found that she was having a heart attack. They took her immediately to the catheterization lab, did a catheterization, put in a stent, and she is fine, although she's on a lot of new medications. But this was completely unexpected. And the reason it's unexpected is if you look at this chart of men and women, women often present differently than men do with their heart attacks. Women often will have back pain, shortness of breath, stomach aches, like they're having food poisoning, sleep disturbances, fatigue, whereas men tend to have more of the what we think of the usual kind of things, which are sweating, pain in the chest, pain going down the arms, shortness of breath. So this is one of the reasons that it often doesn't come to mind that a woman could be having a heart attack. This is the study that I was talking to you about. So this was done in 2014. The Women's Heart Alliance conducted a nationwide survey to find out what women thought about heart disease and to find out what doctors thought about heart disease. They interviewed over 1,000 women and over 200 primary care practitioners, family practitioners, cardiologists. And the results were pretty frightening. 45% of women were not aware that heart disease is the number one killer in women. Almost half of women said it was common for them to cancel or postpone an appointment because they had not lost weight since the last visit and they were embarrassed. But even worse was when they asked clinicians, doctors, nurse practitioners, how many of them thought that heart disease was the primary concern in women? Only 39% were. And when asked, so what do you think really is the number one problem with women? They said it was their weight and breast health. So I think it's very important, at least for all of us, to make sure when you go to a physician to say that you want to be sure that your heart parameters are normal. And that goes to cholesterol and blood pressure, extremely important. Family history may or may not play a role, physical activity. Rosie O'Donnell, the comedian, had a heart attack very young, and she now has taken it on as a mission of hers to go around the country talking about her heart attack. So I just want to show you a little clip of that.
It's a stand-up comedy special about my heart attack that I had, trying to inform women what goes on when you have a heart attack, how you're going to know. And we got a little clip. Take a little look. My little comedy documentary. Hot, exhausted, pain, pale, puke. Hot, exhausted, pain, pale, puke. Hot, exhausted, of pain, pale, puke. Say nothing. Exhausted, of pain, pale, puke. I think we should get like pain.
Okay, so let's move on to a different topic, which is hormone replacement therapy. Many people, when they go through menopause, which average age is about 50, people have tremendous, some people go through it without any problems at all, whereas some people will have insomnia, mood swings, night sweats, vaginal atrophy. In the old days, like my mother's generation, everybody was put on hormone replacement therapy because they didn't know of any downside, and it was thought to keep osteoporosis away and help your brain and help your heart. But as the years have gone on, we've learned that actually hormone replacement therapy is associated with a higher risk of heart disease, strokes, and blood clots. So then the opposite happened. Nobody was prescribing hormone replacement therapy. So now we've backed off of that a little bit, and it turns out it is probably safe to use hormone replacement therapy around the time of menopause, usually for about 5 years, to help women get through the symptoms. But after age 60, it starts to shift a little bit. And after age 60, we do see a higher risk of heart disease, of strokes, of blood clots. And they've studied all different forms of hormone replacement therapy, and they found that almost all of them do cause these symptoms, with the exception of transdermal hormone replacement therapy, which you see there in the picture. It's a patch, and it doesn't get absorbed the way the pills do, and it helps with symptoms. So it is something that one can use in place of symptoms. Now, for many people, vaginal atrophy is very common after the menopause and after the drop in estrogen. And I want to talk about vaginal estrogen. Vaginal atrophy occurs after menopause, and it's a pain for a lot of people. It can cause vaginal dryness, pain and bleeding during sex, which is, as I mentioned, is called dyspareunia. It can cause itching, irritation, burning, discharge, urinary symptoms, and also it can cause urinary tract infections. So this is why in many women who are older, we see recurrent urinary tract infections. It happens in at least 50% of postmenopausal women, and probably more. It's very underreported, because you can imagine when you go to your clinician and you have a 20 or 30-minute visit and you have a whole list of things, it's probably low down on the list. The vaginal dryness and the atrophy is due to decreased estrogen. Now, how do we treat this? Well, if you go to the North American Menopause Society, they recommend that you use non-hormonal vaginal lubricants for painful sex. So lubricants such as Replens or KY jelly or Astroglide, and they recommend increasing sexual activity. Now, anybody knows that if you're having painful sex and someone tells you to have more sexual activity, you're probably not going to raise the issue again. So what do? We know that even though the systemic hormones are good for a very short period of time, they're really not recommended for just vaginal atrophy, because of the potential side effects. We know that vaginal estrogen is helpful. It does increase blood flow. It increases the epithelial lining. It increases secretions, and it really does help with the atrophy. The question is it safe? And so I want to show you a study. But first, I want to show you the different forms that vaginal estrogen comes in. The first one is the vaginal ring called the E-string. It's a round plastic circle that looks a little bit like a diaphragm, only it's got a hole in the middle. And around the outside, it's filled with estrogen. So it slowly ekes out estrogen on a very regular basis. You put it in, it stays there for 3 months, so you don't have to do anything. At the end of 3 months, most of the estrogen is out of the ring. And so you take it out and you pop in a new one. Second alternative is vaginal cream, where it comes in a toothpaste, looks like a toothpaste, and you fill up the plunger. You put this in the vagina and you plunge in the cream. You do this 1 to 2 times a week. And some people actually put it around the outside. And so that can be very helpful. The third way is also a plunger, only it has a pill instead of the cream, so it's a little less messy, but for some reason it's gotten exorbitantly expensive. But it works the same way. You put the plunger into the vagina and you pop out this pill and you do it 1 to 2 times a week. And the big question is it safe? So your doctor gives you the prescription, you take home the package, you open it up, and this is the first thing you see. You see this booklet warning you that this vaginal estrogen can cause endometrial cancer, heart disease, breast cancer, and probable dementia, and that these risks should be assumed to be similar for all estrogens and all doses. So, of course, that's very frightening, but the question is it true? So that's what these studies looked at. This is a study that was done in 2018 in the journal Menopause. And what they did was to study women who were taking estrogen vaginally and those people who were not taking vaginal estrogen. And what they found was when they compared heart disease, fracture, deaths from any cause were actually lower in women who used vaginal estrogen. And in terms of stroke, breast cancer, colon cancer, uterine cancer, there was no difference between estrogen users and non-users. And one big plus of vaginal estrogen, particularly the cream, is that in women who are getting recurrent urinary tract infections, if you use this vaginal estrogen a couple of times a week, it can cut down the incidence of urinary tract infections by 50%. Okay, I want to talk a little about sexuality in older adults. This is something that people don't talk about very much. And you don't see it much in the medical literature, but it's coming out more and more in the lay press. In fact, a couple of months ago, the New York Times had a huge article about it, which you may have seen in their magazine section. According to a 2018 survey by AARP, almost 2/3 of people said that they were interested in sex, and more than 40% of Americans ages 60 to 80 are sexually active. So that's interesting. And I think what we are finding is that as people get older, if they are in a relationship, then many times the kids are gone or they've retired and they have more time and they feel more relaxed. So they may be more interested in sexual encounters. Also, some people may have lost their partner, and so they may be looking for new relationships. So some of the articles that have come out, the National Council on Aging, that found that nearly half of all Americans over 60 are having sex at least once a month. But again, we don't know very much about it. And something called Health Day wrote an article about sex in seniors called the 70-year itch. National Institute of Health are now dealing more with sexuality and intimacy in older adults. WebMD warns that safe sex is still important. So for people who are venturing into new relationships, they have to be aware that they still have to be careful. And the problem is that if there are problems, either with men or women, most people say they would really prefer to talk about this with their physicians. The problem is that there's often not enough time. Often the physicians are not trained in how to deal with these problems. Sometimes the physicians are young enough to be the children or even the grandchildren of some of the people asking these questions. And so many of the physicians just, as they say, don't want to open Pandora's box. So I think most of you are familiar with this picture. This is an ad for erectile dysfunction. So erectile dysfunction is very commonly discussed. I think everybody knows about Viagra. These ads used to be commonly on the Super Bowl and all the football games. They recently took them off because they felt that they weren't appropriate for, since many of the watchers were younger people. But how many of you have ever seen an ad like this, where they talk about a problem that women have, the dyspareunia, which is painful intercourse? So this is something I want to talk about because this is a problem for women who have decreased estrogen and whose sex has become so painful that they actually don't want to have it anymore. So I want to tell you this, that I just learned. This has been talked about more and more, but it's amazing how few people know about it, that vaginal estrogen and vaginal lubricants may help many people with the pain of intercourse, but they don't help everyone. Some people are still having a lot of pain. So lately there have been articles talking about lidocaine gel. Lidocaine is a pain reducer. It's what we get in our mouth when we go to the dentist. It's what we have in these patches that we put on our skin when we're having aches and pains. But there is a lidocaine gel that is good for what we call the mucosa, which is internally. You can buy them over the counter. You can buy lidocaine gel 4 or 5%. Probably the most common place to get it is hemorrhoidal cream with lidocaine, such as Preparation H or something like that, where it says that they have lidocaine in them. And you can put this right at the vaginal opening or inside the vagina if that's where the pain is. You do it just a few minutes before intercourse because it works almost immediately and it doesn't last terribly long, usually an hour maximum, but it is really quite effective. So to take care of dyspareunia, you have this threesome here. You have vaginal estrogen in any form you prefer. You have vaginal lubricants, and you have hemorrhoidal relief cream with maximum strength lidocaine formula. Okay, so while we're in the same geography, I thought I'd talk a little bit about organ prolapse. So organ prolapse is extremely common once people get over the age of 50, and that is that an organ drops out. It's often really hard to know what is dropping out. Even doctors often on examination can't tell exactly what's coming out. And usually women tend to report it because they notice it when they're in the shower or when they're on the toilet, they'll feel a bulge below. Often, if you're in a gynecologist's office and you're lying on your back, the bulge will go back in, and so they don't see it on a routine exam. There are lots of reasons that this happened. Childbirth makes the muscles below weaker. As we get older, it happens. People who are overweight can get more chronic constipation, having a hysterectomy. So there are a lot of reasons that somebody might have prolapse. They usually don't cause major problems, but they can be very uncomfortable. It can be embarrassing. It can cause the urine to be blocked so that you get a little bit of spillage around the prolapse and incontinence. It can interfere with sex. So the usual treatments for this are Kegel exercises, having surgery where they can surgically fix the prolapse, or for women who don't want to have surgery, there are pessaries, and I want to talk just a touch about pessaries. So pessaries have been around since the Greek times. This is what they used to look like. Fortunately, they don't look like that today. We have various shapes, various sizes. You have to be measured by your gynecologist because if it's too small, it's going to fall out. If it's too large, it can cause ulcers around the side of the vagina. But they can be extremely helpful and push up the prolapse so that your symptoms are basically taken care of. They have to be removed periodically and cleaned. In this country, we generally recommend every 3 months you go to the doctor, usually the gynecologist, who takes out the pessary, inspects the inside of the vagina to make sure that there are no cuts or any kind of bruises or any problems from the pessary, cleans it off and puts it back in. In England, they did a study where instead of every 3 months, they did it every 6 months. And they found that there were actually fewer problems when they did it every 6 months. So if you have a pessary and you haven't gone in 3 or 4 months, that's probably a good thing. Okay, now I want to talk about preventing dementia. What can we do when we're still young, middle-aged, to prevent dementia? A lot of studies have been done looking at 80 or 90-year-olds, and we know that physical fitness is good for your whole life, but there have been very few studies looking at people in younger ages, in their 40s, to see if there's anything they can do to long-term prevent dementia. So I'm going to show you a study that was done in Sweden to look to see whether people who were more cardiovascular fit in midlife were less likely to get dementia. They studied them for 44 years. So that's a long study. They looked at over 1,000 women with a mean age of 47. So many of them were in their late 30s and early 40s. They started in 1968, and they divided them into groups to see how physically fit the women were. And then they did memory tests on them every few years to see how their memories were doing. So what they found after all these years was that about a quarter of the women developed dementia, which is pretty typical. About a quarter of people develop dementia. But then they divided the women into the 3 fitness groups, and they found that there was a big difference in who developed dementia based on how much fitness you did. So for the people who really did almost nothing, 32% of them developed dementia. For the people who were mediumly fit, those people were sort of the average. 25% of them developed dementia. But for people who were the really high physically fit people, only 5% of them developed dementia. It's not clear why. I mean, we can speculate that you keep your whole heart and brain in good shape, but the more physically fit you were, the less likely you were to develop dementia. Okay, I'm going to show you a woman. She is here, 97 years old, and she has exercised just about every day of her life, and she is a strong believer in exercise. I should know because this is my mother. So here she is on the treadmill. And she really kept going until, unfortunately, at age 97 and a half, unfortunately, rushing to the door to answer the door, she fell down and broke her pelvis. However, once she got out of rehab, she went to go right back into exercising. And so here she is, back on her feet again. And as you can see in the foreground, there is her 2-year-old great-granddaughter who she says, you have to exercise, you have to exercise. And this is not just a summer sport for her. She keeps going in all kinds of weather. So what has this done for her brain? Well, here she is, with her favorite person, who is Mr. Google. We had told her that we were going to let her see Hamilton, which was coming to TV. So she wanted to know what was Hamilton. She wanted to listen to the music so she would have a better idea of what she was going to watch. So here she is listening to Hamilton. Here she is, that she's now 98 here. Okay, so now I'd like to talk, and again, this is for men and women. Once people hit 65, there are several vaccinations that are recommended by the CDC. So I'm just going to go over those quickly. So the flu shot is recommended every year because it does change, it mutates, and so we need to get one every year. But I would like to put a plug here for not getting it too early. In the summertime, July and August, you will see big signs in the pharmacy saying, get your flu shot while you're here, one-stop shopping. That way you don't forget it later on. But the trouble is that it turns out that the efficacy of the flu shot decreases by 7% every month. So by the time flu season rolls around in December, you've already lost a lot of your antibodies that'll protect you against the flu. So my recommendation to people is always to wait, preferably till early November, to get the flu shot. Next is the pneumonia shot. Usually it's just once per lifetime. But the original flu shot was the 23, the pneumococcal 23, and then later on came the Prevnar 13. So it was recommended that you get both of these. If you hit 65 and you hadn't gotten either one, you would get one, usually the Prevnar 13 first, then wait a year, and then get the pneumococcal 23 a year later. But now we have a new kid on the block, which is the Prevnar 20. So if you have not had any pneumonia vaccines by the time you get to 65, if you get the Prevnar 20, you're one and done. You don't need to get any more. If you've only had one of the other two, either the 13 or the 23, then you can get the 20, and again, you're finished. The TDAP, which stands for tetanus, diphtheria, and pertussis. So pertussis is whooping cough, and for any of you who have little kids or little grandkids, you know that their parents are quite insistent that you have the P for pertussis, so you don't either give or get whooping cough from the kids. That shot is given every 10 years. Next is the Shingrix. That's the shingles shot. This has been miraculous as far as I'm concerned. The original shingles shot, which came out in 2006, was made out of a live virus. So there were many people who couldn't get it, people who were immunosuppressed or taking chemotherapy or taking prednisone. And it also wore off very quickly. So by the time you hit 85 or 90, you had no protection. But this shot came along 7 or 8 years ago, and it has really stood the test of time. It now, 7 years later, it still remains very effective, up to 90%, no matter what age you are. And it is excellent at preventing shingles. So the good news and the bad news is that it's 2 shots instead of 1. So you get the first shot, and then 2 to 6 months later, you get the second shot. And many people will have side effects the next day. So I warn them, they may have a fever, they may feel like they have the flu, but it's just your body reacting to the shingles vaccine, and it is worth it. The other good news is that it used to be very expensive, but as of January 1st, it is free. So now all of the insurance companies are supposed to be covering it absolutely free. And then, of course, there are the COVID vaccines, which most of you are familiar with. I still get questions about whether people should get the bivalent vaccine. And I say, frankly, I think you should get whatever vaccine you can, because I get at least a call a day of people getting COVID, wanting Paxlovid. And so my feeling is that COVID is still out there, and you still have to be careful. I still recommend wearing masks whenever you're in a grocery store or around other people. The next thing I want to talk about, which is something that's so important and so ignored, is hearing loss. It is probably the greatest sensory disability worldwide. Unfortunately, the United States Preventative Services Task Force, which is what all clinicians look to tell them what to screen for, says that there is inadequate evidence to screen for hearing loss in people over 50. But I feel that that is just not true. There are a lot of things that are associated with hearing loss, not just the fact that you can't hear what's going on around you, that you often get ignored in the office because when you can't hear what's going on, they'll turn to the person next to you and talk to you, or they'll yell loudly. To say nothing of the fact that masks have made a huge difference in people who can have some hearing, but also lip read. I just want to show you this, by the way. This is another kind of mask that many teachers use. And we've been encouraging physicians to use this too, because at least people can lip read while they're wearing their mask. So there's a lot of research showing that not only is hearing loss annoying itself, but it also leads to gait imbalance. And there is evidence now that it can worsen the incidence of dementia. So for instance, here's one study. Unfortunately, the letters were blocked out, but if you look here at the dotted line at the bottom, this is people with normal hearing, and you can see that the other line is people with who are not demented. But here you see that as the rate of hearing loss goes up, so does the rate of dementia go up. 2/3 of all people over 70 have hearing loss, and yet only 14% of adults wear hearing aids. So why is this? Well, people say it's because they're so expensive, but it turns out that in the United Kingdom, where the National Health Service pays for hearing aids, they also have a rate of 14% of people wearing hearing aids. So there are a lot of reasons. People don't like them. They're too expensive. They don't want to get their hearing checked. It makes them look old. But more and more studies are showing that using hearing devices was associated with a 19% decrease in cognitive decline. So not only is there less dementia, but once people start wearing hearing aids and improving their hearing, there's actually a 3% improvement on their cognitive test scores. So my feeling is that the task force needs to revise its recommendations on screening because it is extremely important. I wanted to bring this up because cochlear implants, which used to be thought of only for children or young adults, is now being used more and more in people who are 55 and older. It can be something that's a little difficult to get used to because the brain has to completely renew its way of hearing things. But even in people who have mild dementia, can benefit from cochlear implants. This has been a big thing. Just in the last few months, hearing aids have gone over the counter. So even though some people prefer still to get their hearing checked and get a prescription for hearing aids, you don't have to. You can go into a store and pharmacies, Costco, any of these places will sell over-the-counter hearing aids. They are for mild to moderate, not for extreme hearing loss. There are many different shapes, sizes, colors. You don't need a prescription. You don't need a hearing exam. Prices range anywhere from $100, but usually less than $1,000. And if you're going to get them, my suggestion is that you check to be sure that there is a money-back guarantee. Many of them come with a 30-day trial period and will refund you if you don't like it. But if you do try it, or you have somebody who's going to try it, make sure that they really make an effort. Have them wear them every day until they can get used to them, because hearing aids take a while to get used to. This is something that we have in our office, and I think is a great thing to have even at home if you have somebody who has a real hearing problem. It's called a pocket talker. You can get them on Amazon or something similar to this, where you put the headphones on the ears and then you speak. You turn it on here on the side, and you can turn up the volume, turn down the volume. It runs on batteries, and you can speak into this. And I can't tell you how many times in the office somebody will come in and they'll shake their heads and say, I can't hear you. And I'll put this on them and it's like the light was turned on. All of a sudden they say, oh, I can hear you. Turn down the volume. So these are good. They're good to take with you to an office visit, or if you're just even sitting around the dining room table, if you want to put this in the middle of the table, then the person who has hearing problems can hear more of what's going on, or you can have a conversation with somebody. So they really are worth getting. Now, another thing I wanted to talk about here is coffee. So why talk about coffee in this talk? Well, again, I'm all for prevention, and many people, as they get older, have stopped drinking coffee because they think they're not supposed to. They think it's a diuretic, get palpitations, raises the blood pressure. So these articles have been coming out both about coffee and tea. This particular one is about coffee. Coffee, as you know, is an extremely popular worldwide beverage, and more research articles are coming out about how it may reduce the risk of Alzheimer's dementia. So what they did was they took almost 230 people who were normal cognitively. They asked them how much coffee they drank, and then they did memory testing. They did MRIs, PET scans, and they followed them for over 10 years. And what they found was that the more coffee you drank, the better your memory was. They estimated that increasing your coffee intake from 1 to 2 cups a day could provide an 8% decrease in memory decline and up to 5% decrease of Alzheimer's disease. And in fact, coffee consumption of more than 3 cups a day was associated with a 50% reduction in dementia risks. So here's how they divided it up. This is dementia here. So the lowest coffee drinkers, or people who didn't drink any coffee, had the highest dementia. Middle was middle, and people who drank the most coffee had the lowest risk of dementia. Okay, so what about those palpitations? This came out in a very respected journal, JAMA, Internal Medicine, in 2021. They looked at almost 400,000 people. They followed them for almost 5 years. Out of those total, out of the almost 400,000, almost 17,000 developed some sort of arrhythmia, whether it was heartbeat going fast or palpitations or atrial fibrillation. But they found that the inverse was true with coffee, that for every cup of coffee, there was a 3% lower risk of some kind of arrhythmia. So this particular article, which went on for many years and many individuals, did not show that coffee caused arrhythmias. What about tea? Again, these are 2 articles that came out recently in 2022, showing exactly the same thing, that there was lower mortality as well as less dementia in caffeinated tea drinkers. So you can feel free, not at night because you don't want to stay up all night, but you can feel comfortable that these things are probably good for your brain. All right, I would finally like to end with another article, which is from another journal called the Wall Street Journal. Ann Tergeson writes an article about aging, usually every year. And this one, she wrote, Why Everything You Think About Aging May Be Wrong. So we have stereotypes of later life. We think about old people sitting in their rocking chairs, depressed, lonely, decline. But actually, studies show that usually and often is not true. Any of you who are older know that we stress out a little bit less about things that when are in our 20s and 30s, we do stress out about. We've learned a lot from life, and I think it helps us to be more patient and more calm. These are some of the myths she talked about. So myth number 1, depression is more prevalent in old age. This turns out not to be true. In fact, the most depression is in more the middle age, the 30s and 40s, where people are struggling with relationships and careers and often young children and often taking care of parents. But later on in life, when some of those stresses have calmed down, we can calm down. Myth number 2, cognitive decline is inevitable. Well, we do know that after age 85, about 25% of people will have some cognitive impairment, but that means that 75% of people do not. And they do recommend that we keep our brains sharp, getting together with people, doing whatever, crossword puzzles, learning a language, watching, getting on to Google or using your iPads for things. Myth number 3, older workers are less productive. Well, I think if any of you work together with people or have ever hired people, you know that older people who are making up more and more of the labor force are often the most reliable workers. Myth number 4, loneliness is more likely. That turns out not to be true. And myth number 5, that creativity declines with age. Actually, the opposite is true. As people have more time and pursue more interests, many people discovered things that they didn't even know they had inside them. So this is the dividing line. When it comes to asking people, how old do you think somebody is when they become old? So these are various answers, depend on who you ask. So if you ask people under 30, what age do people become old? They say 60. But you can see that the older you are, the older you think old age starts. And my guess is that even now the 74-year-olds who you ask will think that old age starts at a much later age. Here they asked people, how do you feel relative to your own age? So again, the under 30 group, most people felt their age. Some people felt older, some people felt younger. But as you get into the 75 plus, you see that the majority of people, really at almost any age beyond 30, feel younger than their age. Very few people feel older than their age. And, some people feel their age, but most people feel younger than they are. So what about the expectations and the reality? In these blue lines here, you see when they ask people under the age of 65, what do you think is going to happen to you as you get older? And then in the green line, these are the things that actually do happen to people who are older than 65. So you can see in every category, what really happens does not meet our fears in terms of memory loss, driving, having a serious illness, not being sexually active, feeling sad or depressed, not feeling needed, loneliness, having trouble paying bills, and being a burden. So even though we fear these things, often the majority of the time, they don't come true. This was in the Wall Street Journal recently, that they were having trouble finding older models because apparently there is a sky-high demand for older models. This was in the Wall Street Journal, January 17th, 2023. These are women in their 60s, 70s, 80s, and 90s. They are creating a silver wave in the modeling industry. In fact, they say they even get stopped in the supermarket for people asking them where they got their outfits. And just to end, again, I want you to remember this age and life satisfaction. So these are scores of life satisfaction, and these are the various ages. So you can see starting at about 13, life satisfaction tends to dip until around your 50s. And then it starts to rise and rise and rise so that people in their mid-90s express the highest life satisfaction. Okay. And here's mom doing her upper body weights. Okay, I tried to leave a little bit of time for questions.
Yes, we do have some questions in the Q&A. Hold on one second. All right. And then for those of you who came a little late, just to reintroduce myself, my name's Heidi White. I am the Group Fitness and Wellness Manager at JCC Greater Boston. First question we have, what age do you recommend getting the Shingrix vaccine?
The recommendations are to start at age 50. I mean, personally, I would love for everybody to get it, but the age is 50. And for a while, it was a little tricky because until about 1997, the people would just get exposed to chickenpox. And the majority of people under the age, or I'm sorry, over the age of 50 have had chickenpox. Many people don't know that they've had chickenpox. And it's really, some people just have such a mild case that they didn't know they had it, or some people may not have gotten it, but the majority of people have. But in the mid-90s, the chickenpox vaccine came out, and it was really unknown whether people who got the chickenpox vaccine would develop shingles. But as it turns out, since we still are not 100% sure, the recommendation is that everybody over the age of 50 should get the Shingrix vaccine. And it doesn't matter if you've had shingles or if you don't know if you've ever had chickenpox or not, you should still get it. Now, if you've had shingles, it's sort of like COVID, that you'll probably have so many antibodies in you from the shingles itself that probably it makes sense to wait a few months before you get the Shingrix vaccine.
Great. This one, at 54, I recently found out I have osteoporosis. Do you feel osteoporosis can be treated naturally with vitamins and exercise, or do you advise always using medication?
So you are young. And I think what would be important is to get what they call a FRAX, F-R-A-X. You can actually do it online yourself if you've had a bone density score, because they help you determine what your 10-year risk is of breaking a bone. That's the big fear with osteoporosis, that you're going to fall and particularly break a hip, because hip fractures can be really a pain and can be life-changing. So that's what we want to avoid. So what this FRAX does is it takes, if you have a bone density scan and you have a score on it from your bone density scan, it can tell you what your risk is of breaking a hip. So some people who are at very low risk can probably get away with calcium, vitamin D, and good exercise. And that means, jarring type of exercises. For instance, swimming is really good for your heart, but it doesn't do anything for your bones because you really need to pound your bones to get them strong. Running or jogging or even hopping around, dancing is really good exercise for your hips. But what you just saw my mother doing, which is lifting weights, is very important for the spine, which is another place that you get osteoporosis. And because lifting the weights can pull on the muscles of the spines and strengthen them. Now, if you have really severe osteoporosis, and there are other risk factors, such as if you need prednisone for 3 months or more, or if you're on certain chemotherapies, or if you're on letrozole or one of the breast cancer therapies, or if your parents had osteoporosis and had a hip fracture. For those people, it might be reasonable to think about medications. There was an article in the New York Times. Our osteoporosis doctor got crazy about it because the article wrote about all the side effects that you get with the osteoporosis drugs. And it was such a scary article that prescriptions for the osteoporosis drugs dropped by half and the incidence of hip fractures went up. So I know many people are afraid of the osteoporosis drugs, and they have shortened the amount of time that people take them. When they get into your system, they get into your bones and they stay there for years, which is a good thing. You have many choices. You can take a pill once a week, Fosamax, and We used to say stay on it forever. Now it's 3, even after 3 years, you've gotten a tremendous boost to your bones. There's a once a year intravenous that's similar to Fosamax, only it's intravenous, and that's only once a year. So that's much more convenient. And then there are a lot of the newer drugs like Prolia, which you get an injection every 6 months, which it's very good. It really builds up the bones, but I don't like it because you have to then stick with it. Once you stop Prolia, it can seep out the calcium and make your bones weaker. So I would say at 54, you should just try to find out how severe the osteoporosis is.
Can you recommend a good health newsletter that might be especially focused on women's health?
Actually, there is let me just see here. Do I have it here? Downstairs. So Harvard Health Letter has a women's health letter. You can Google that and take a look at it. It's the Harvard Health Letter for Women.
Okay. This one I'm going to have to spell. Do you recommend phosphat, YL memory supplement to prevent dementia?
Oh, so far, sadly, there have been no supplements that help prevent dementia. So far, the research is really mostly going into treating dementia. But for preventing dementia, with dementia, in this country, Alzheimer's disease is the number one cause of dementia. It causes about 60-70% of dementias. Those are hard to prevent, although, as you saw from that one thing I showed you, they're being very physically active, making sure your hearing is okay, drinking some tea and coffee, those things may help. The other types of dementia, like vascular dementia, that's a different story. That we really can help with. Anything that you do for your heart is the same good that you do for your brain. So eating healthy diet is very, very important. And you've probably all heard about, the fruits and the vegetables and the nuts, keeping your blood pressure under good control. The latest studies show that they really want blood pressures to be closer to 120/80. In older people in their 80s, 90s, you really have to walk the line between getting the blood pressure so low and having the side effects of the medications. But years of high blood pressure can affect the brain with little mini strokes, as well as the heart.
How common is it to get shingles more than once?
It's about 6 to 10%. It's very disappointing to get it twice. So that's why the recommendation is to get the Shingrix vaccine, because that will decrease your second occurrence.
And related, it says if you have had an older shingles vaccine, should you now have the newer vaccine?
Definitely. That older and believe me, I was thrilled when it came out, and it was the first step toward doing something about shingles. But that was many years ago, and my guess is you probably don't have many antibodies left from that. So definitely should get the Shingrix.
At what level of hearing loss do you recommend to start wearing hearing aids?
Well, they say that many people think that they don't have hearing loss. And so I would say you have to go by rather than a measurement. Are you turning up the TV too loud? Are you asking people what did you say? If you're in a group of people and you cannot hear the conversation, those are usually signs that you may need hearing aids.
Final question here. What supplements do you recommend?
Well, a lot of people are taking a lot of vitamins. Usually the vitamins help when you have a vitamin deficiency. So, for example, we like to check vitamin D levels at least once because we know that people who are really low on vitamin D can have all kinds of things. Certainly your bones can be too low, too weak. There is some thought that it can even lead to depression. They call it the sunshine vitamin. So those people, I think, should have vitamin D, although you don't want to overdo it with vitamin D because too much vitamin D can cause too much calcium in your blood, which is also not healthy. Another vitamin is B12. Most people have adequate amounts of B12, but because many people are taking medicines for reflux, and those medicines can decrease the absorption of B12. And so it's always good to get a B12 level when you go for a blood test and then to supplement B12. Beyond that, there are known, it's really only to treat deficiencies. Having said that, my mother has taken a multivitamin all her life and she just turned 100. So what can I tell you?
A couple more questions just came in. Is it accurate that over-the-counter hearing aids are not as effective as prescribed ones?
We don't know. Actually, they've been out so recently that we really don't know. If you will ask any audiologist, they will tell you that the prescription hearing aids are better, and perhaps they are. I think time will tell. But I think for people I think what the over-the-counter hearing aids do is that they help push some people over the line where they absolutely refuse to get a hearing aid. Here, if somebody brings it home for them, maybe they'll try it out. Also, the price differential was a big thing for many people. So I think if you can get a less expensive hearing aid, it's worth trying out. I think time will tell whether or not they're equal or not as good as prescription hearing aids.
Okay.
I want to mention something though too that, oh yeah, I did mention the cochlear implants. Okay, sorry.
Final two questions. And I know you talked about the symptoms after getting the shingle shot. How severe are the symptoms after Shingrix?
So the symptoms, some people have no symptoms. Some people get a really, really red arm that looks like an infection. Fevers of up to 102 or 103, feeling achy all over. But I would caution people not to reject the Shingrix shot because of that. I would just schedule it at a time where you can lay low the next day. Don't do it the day before you have to go to a wedding or some sort of other event. And it can be just as bad with the second shot as the first shot. I just think it helps people, prepare themselves that they may be sick the next day. The other thing is, if you do feel sick, you can take a Tylenol. But with any of these, including the COVID shots, they want you not to take something like ibuprofen or naproxen because those are anti-inflammatory and they don't want to decrease the effectiveness of the vaccination.
Final question. This is a two-parter. Treatment for insomnia and treatment for hair loss.
Okay, insomnia that's a big problem. The number one best treatment, which very few people do, is called cognitive behavioral therapy, where they try to go through all the things that can keep people up, like watching TV or reading on your computers or your iPhones. Try not to drink coffee, try not to drink anything really after supper so that you don't have to get up in the middle of the night to go to the bathroom. Some people will try melatonin, and that can be very helpful. We get concerned about things like Benadryl, which is what's in Tylenol PM, or ibuprofen PM. They are helpful for some people, but they also can increase the risk of falls, so you have to be careful with that. And then there are medications, some of which are helpful and some aren't. Some studies have shown that herbal tea, like sleepy time tea with chamomile in it, lowers stress levels. But sleep is a problem. Try not to watch the news before you go to bed. In terms of hair loss is extremely common as people get older. There is, if you are really compulsive and stick to it, you can get minoxidil over the counter, which is a foam that comes, 5% foam. Actually, you can get the men's. It comes in men's and women's. The women's is twice as expensive, but it's exactly the same thing. But basically, I'll show you. You have to put it on every day. So basically, every place that you see on the crown, it takes 5 to 10 minutes to put it on every day. And it will increase hair growth. There's no question. It takes a while. A lot of men use it who are getting bald in the front. However, it has just been approved for pill form. The minoxidil or finasteride, you can ask your physician about it. And it has just been approved. And honestly, it's easier to take a pill than to mess with the hair, but you can do it with the hair.
Great, wonderful. Well, thank you so much, Dr. Solomon, and special thanks to Beth Israel Deaconess Needham and Beth Israel Deaconess Medical Center for sharing this important information about women's health and aging. If you would like to hear this presentation again, or if you know someone who might benefit, we will be posting the recording on the JCC Greater Boston website page, bostonjcc.org, on the Wellness Speakers Series page. Please also save the date for our next topic on men's health and aging with Dr. Jeremy Wyman on Tuesday, March 21st at 5 p.m. And if you have any questions about JCC Greater Boston's programs, you can email me, hvwhite, as in Heidi White, at jccgb.org. And again, thank you so much, Dr. Solomon. This was wonderful, so informative.
My pleasure. Thank you.
Good night, everyone.